Hello, my name is Parth Patel, and I'm here to present our project on the epidemiology of United States ocular injuries at home in preschool-age children. My co-authors include Dr. Aditya Upluri, Dr. Marco Zarbin, and Dr. Nilakshi Bhagat. This project was conducted out of the Institute of Ophthalmology and Visual Science at Rutgers, New Jersey Medical School. I'd like to thank the Society for Academic Emergency Medicine for the opportunity to present our findings. To begin, in 2017, there were nearly 14 million ED visits for children under the age of 5 in the United States, with the most common setting of injury being a private residence. Injuries to the eye are a common cause of ED visits in the pediatric age group, especially in those children ages 1 to 5. The goal of our study was to characterize the epidemiology of pediatric consumer product-related eye injuries that occurred at home in children less than the age of 5 in the United States in the last 2 decades. We utilized the National Electronic Injury Surveillance System to source information for this study. NEIS injury surveillance system is run by the Consumer Product Safety Commission and gathers data on consumer product related injuries and is from a representative sample of 100 US hospital EDs. Inclusion criteria for this study included ocular injury that occurred at home between January 1st, 2000 and December 31st, 2019 in patients under 5 years of age. Our patients were divided into the age groups of less than 1-year-olds, 2-year-olds, 3-year-olds, and 4-year-olds. We found that there were an estimated 258,071 total ED visits for children under the age of 5 due to an ocular injury occurring at home, with over 58% of injuries occurring in males. Of these patients, 13.6% of the patients were under the age of 1, just over 24% were 1-year-olds, 26% were 2-year-olds, 20% were 3-year-olds, and the remaining 16.3% were 4-year-olds. For all ages, a greater number of ocular injuries presented to the ED on a weekend compared to a weekday. The incidence of consumer product-associated ocular injuries at home per 1 million in the population is shown in this figure for the last decade. There was no significant changes over the last decade. We also found that detergents and chemicals accounted for a third of all consumer product-related eye injury, as shown in the figure below, in preschool-age children, followed by toys as the second most common category. Similarly, detergents and chemicals and toys accounted for the top 2 categories in both males and females as well. In terms of subgroups within detergents and chemicals, the most common subgroups were laundry soaps and detergents, non-cosmetic bleaches, and general purpose household cleaners. The most common eye injuries were ocular contusions, followed by dermal/conjunctival injury, chemical burns, and other. Most patients were treated and released from the ED, suggesting a minor injury, and 19% of the estimated 5,147 patients admitted or transferred to the hospital had an open globe injury, which is defined as a full thickness wound to the eye. The greatest number of ED visits for ocular injuries occurred in April and May, while the fewest occurred in February. In conclusion, preschool-age children who presented to the ED for consumer product-related ocular injuries in the last 2 decades were mainly 1- and 2-year-old males. A third of the injuries were due to detergents and chemicals. Ocular contusion was the most common diagnosis, and average daily ocular injuries were higher for weekend days compared to weekdays. We found that there was a 12.9% decrease in the estimated number of consumer product-related eye injuries in our age group in the 20-year period from our study, 2000 to 2019, compared to a previous study in clinical pediatrics by Pollard in 1990 to 2009. They had found that there were an estimated 296,369 ocular injuries for the 2 decades between 1990 to 2009, compared to 258,071 in our study from 2000 to 2019. Similar to the Pollard study of the previous 2 decades, chemicals were the most common cause of ocular injury presenting to the ED in children ages 0 to 4. Pollard also showed an estimated frequency of 126,016 ocular injuries due to chemicals in children less than 5 years of age in the 2 decades for their study, compared to 90,345 ocular injuries at home due to detergents and chemicals in children less than 5 years of age for our study. For children 4 years and younger, the mean annual rate of ocular injury for our study was 573.1 per 1 million in the population from 2010 to 2019, compared to 1,131 ocular injuries per 1 million in the population for their study from 1990 to 2009. These findings can in part be attributed to regulatory bodies and their campaigns, some of which include the American Academy of Pediatrics, the Consumer Product Safety Commission, and the National Safety Council to educate parents. Some of our limitations are listed on this slide, and they include some of the information provided by NICE, and finally our declarations. All questions can be addressed to myself or any of the other authors present on this study. I'd like to thank Dr. Ocular, Dr. Zarbin, and Dr. Bhagat for the continued guidance. Thank you.
Pediatric emergency department visits by infants for homelessness in the setting of state policy change. My name is Kendall Burdick, and I'm a third-year medical student at the University of Massachusetts. I'll be presenting on behalf of my co-authors listed here. We have no disclosures. Since 1983, Massachusetts is a right to shelter state. It is the only right to shelter state in the United States. What this means is that regardless of bed availability, any eligible family needs to be provided shelter. This resulted in an increase in state shelter system spending. In an attempt to decrease spending, in 2012, the emergency assistance shelter eligibility regulations were changed to be more stringent. A new clause was added that required many families to now prove that they spent a night in a place not meant for human habitation. What does that mean? Not meant for human habitation can mean a public area such as a car, a park bench, but the emergency department also satisfied that policy. As an unintended effect of this policy change, we saw an increase in families and children presenting to the emergency department for homelessness. As you can see, this is the dashboard of patients on one particular night in the Boston Children's Emergency Department, and the red box next to the patient's name indicates that a family was there for homelessness. Our study expands on previous literature and focuses specifically on the infancy period. We did this for many reasons. First, the pregnancy and perinatal period has an increased risk of homelessness. Infants who are born to housing insecure families are more likely to have lower birth weight and longer NICU stays. Furthermore, infants who experience homelessness have an increased odds of poor health and development, maternal depression, and housing and food insecurity. Our study was in the setting of a single urban tertiary care children's hospital. We used a retrospective EMR review, and our study separated into two parts. First, pre-policy from March 2010 until September 17th, 2012, and then post-policy, September 18th, 2012 to February 2020. We cut this off right before the COVID-19 pandemic, as we intend to include a COVID-specific analysis with regards to homelessness. We reviewed all records for infants a year of age or younger, whose primary complaint or ED disposition was homelessness, as noted by an ICD-9 or 10 code, or social work note. Our results were staggering. On the y-axis of this graph is the number of visits for homelessness to the pediatric ED. On the x-axis is the year. Before the policy, which is noted by the gray dotted line, we see yearly visits for homelessness to the PDED under 10 per year. After the policy, we see a substantial increase in visits. We further separated our results to emphasize neonates, which are children 28 days or younger, as this is a particularly at-risk population for adverse events. Notably, the January and February 2020 bar is much lower than the other years because this only involved the first 2 months of the year. So who are these children? These infants are healthy. 68% had no acute medical complaint. 88% received no medication, and 89% had no chronic medical problem. In other words, these children would not be coming to the ED if it were not for homelessness. When we look further into these children, there are racial, ethnic, and language disparities. 24% were Black or African American, 69% were Hispanic, and 43% were Spanish speaking. These demographics are out of proportion to the state demographics. Furthermore, 79% of visits were by children covered by public insurance. In other words, the state may not have had the desired effect of decreased spending and instead just shuttled the spending into a different avenue. In conclusion, these visits are avoidable. There's minimal medical care needed for these children, and they would not be presenting to the emergency department if it were not for homelessness. The presentation to an ED poses unnecessary risk for child and family, from the unnecessary risk of infectious exposure and the stress of just being in the medical environment. As we can see anecdotally, this poses a burden to the emergency department in terms of patient flow and is costly for the healthcare system. The next steps of this study will be to expand our analysis and include all children 18 years and younger. We will also look at the financial impact of these visits. And we will specifically look into the impact of homelessness by COVID-19 pandemic on PD-ED visits. Thank you.
Thank you very much for the opportunity to present today. My name is Jackie Furbacher, and I'm a third-year emergency medicine resident at The Ohio State University Wexner Medical Center in Columbus, Ohio. Today, I'll be speaking with you about the prevalence of food insecurity in cancer patients presenting to an urban academic emergency department. We have no financial disclosures or conflicts of interest to disclose with regards to this research and presentation. Food insecurity is defined as a time period where households were uncertain of having or unable to acquire enough food to meet the needs of all their members because they had insufficient money or other resources for food. Food insecurity affects approximately 11% of US households and has been linked to negative health outcomes, including mental health disorders, diabetes, hypertension, among others. In our urban academic emergency department, we see about 185 patients per day. This means that 20 patients coming to the ED for care may have food insecurity based on the general US population. Literature also shows that there is an increased prevalence of food insecurity in patients presenting to the ED, as well as in patients who have cancer. Rates of food insecurity may change based on various demographic characteristics, such as race, education level, number of people living in the household, location, to name a few. To date, there is no study that examines the prevalence of food insecurity in cancer patients presenting to the ED. The objective of the study was to determine the prevalence of food insecurity in cancer patients presenting to the ED. We developed a prospective observational study that enrolled a convenient sample of patients treated for cancer in the past 12 months, presenting to our emergency department. Upon enrollment in the study, they completed a 20-question survey, and food insecurity was determined using a validated screening tool called the Household Food Insecurity Access Scale Measurement Tool. This tool assesses for food insecurity by asking questions regarding occurrence over the previous 30 days, followed by the frequency of this occurrence, and these responses are then used to determine prevalence. Additional questions focused around demographics, perceived impact of food insecurity on health, and preferred resources. Of note, the study was IRB approved prior to the COVID-19 pandemic. However, the IRB did approve an addendum to the protocol that included questions focusing on the impact of COVID-19 on access to food. Patients were enrolled from June to December 2020. 255 patients were approached for the study in person and via the telephone due to COVID restrictions early in the data collection period. 62 patients were enrolled in the study with a similar rate of consent via telephone and in person. 14% of patients refused consent, while 86% were missed or dispositioned prior to the completing enrollment. After analyzing our results, we found a food insecurity prevalence of 16%. Of those reporting food insecurity, there was an equal number of male and female respondents with an average of 57 years old. 40% of these patients found to have food insecurity also reported having difficulty paying for their medications compared to 13% of those who did not have food insecurity. Education level varied amongst the population reporting food insecurity, with 40% having a bachelor's or associate's degree, and the remaining 60% reporting an education level of some college or less. Of all respondents in the survey, 26% reported that the COVID-19 pandemic negatively impacted their ability to get food. Reasons cited included the lack of food at grocery stores, as well as fear of getting sick. All patients enrolled in the study were asked how they perceived having food insecurity would impact their health. Most common responses were increased stress, followed by being sick more often, increased ED visits, and increased hospital stays. All patients enrolled in the survey were asked what type of food assistance they would prefer if they had needs for food access. Most common responses were money to be spent on food, followed by fresh produce, meal delivery services, and food products. Food insecurity affects patients with cancer presenting to an urban academic emergency department at higher rates than the historically reported for the general US population. This is consistent with previous literature for ED patients and cancer patients. Cancer status and financial strain from the COVID-19 pandemic may contribute to these findings. Specifically, the impact of the pandemic on the prevalence is unknown and potentially meaningful, given that 26% of patients perceived a negative impact on their food access related to the pandemic. Limitations of this study include English speaking only, non-critically ill patients, the time period of enrollment, and the COVID-19 pandemic. This study does represent the only known findings assessing food insecurity of an adult ED patient population during the ongoing pandemic. Patients' perception of food insecurity having a negative impact on their health outcomes is congruent with food insecurity being linked to negative health outcomes. These findings may also inform patient preference for potential interventions addressing food insecurity in cancer patients presenting to an academic urban emergency department. Thank you so much for your time today. Here's a list of my resources used, and I'll be available for any questions.
Hello, my name is Madeline Grady. I'm an emergency medicine resident at UCSF and director of research at ODR. Today, I'll be discussing some of our work from the past year promoting voter registration in healthcare settings. I'll give some brief background on why and how we carried out our work, and then share some key findings and learnings. Voting sends a signal of support or dissent for policies that ultimately shape the social determinants of health. Individuals whose voices are more represented in the civic process will ultimately experience policies that are more favorable to their health. Broadly speaking, civic health describes how well you or your community are able to participate in this process, including through voting. Civic engagement and health have several cross-sectional and longitudinal associations in medical literature. Unfortunately, according to census data, 1 in 4 eligible Americans is unregistered. Furthermore, some groups face disproportionate barriers to civic participation, including young adults, people with low income or education, and certain racial and ethnic minority groups. These individuals also present frequently to the ED. This is where we come in. We have an opportunity as trusted messengers to make use of this demographic overlap and to elevate those most marginalized by our current system. VoteER is a nonpartisan nonprofit founded in late 2019 by Dr. Alistair Martin at Mass General. As the pandemic exacerbated existing barriers to civic participation, we leveraged digital tools to help register patients to vote in healthcare settings. Our aims were to reduce barriers for voter registration for all patients by sharing information in the clinical setting about voter registration safe voting. In doing so, we hoped to raise awareness about civic health amongst patients and providers alike. Our inaugural initiative centered around last year's national and local elections, and the following data is drawn from mid-May through the end of October of 2020. We recruited healthcare workers through email listservs and word of mouth to visit our website, www.voter.org. There, participants signed up to receive free Healthy Democracy kits. These include plastic badge backers that fit right next to your hospital ID, as I modeled there in the middle. The QR and text codes take patients to an online platform to check their status, register to vote, or vote by mail, all from their phones. We also deployed a site-based approach in which hospitals and clinics shared information on posters in waiting rooms, discharge paperwork, and even Zoom backgrounds for telemedicine visits. We trained participants on how to take a few seconds to ask patients open-ended questions about voting alongside their social history. In the following slides, I'll describe high-level participation data from individual and site-based orders, some select data from a survey of students, and de-identified outcome data of total registrations and mail-in ballot requests from our third-party registration partners. This graph shows the number of new individual healthcare workers who ordered Healthy Democracy kits during our study period. The period of greatest growth coincided with the inaugural Civic Health Month, an initiative in which 100 partner organizations, including EMRA, spent a month promoting civic health. From August 1st to 31st, new participants more than doubled, including a max of 254 orders in one day. Almost 60% of individual users were physicians, followed by medical students, nurses, social workers, and advanced practice providers. In addition, a huge variety of other healthcare staff participated, including hospital CEOs, admins, therapists, techs, interpreters, and even an acupuncturist. In total, more than 24,000 kits were distributed throughout the country. Orders came from every single state. The top three were California, Pennsylvania, and New York. In addition, 80 medical school teams participated in our Healthy Democracy campaign, a friendly competition to see who could help the most patients. The most commonly cited motivation for participation in this competition was social and racial inequities, followed by the national election. Furthermore, a majority of these students felt civic health should be included in medical education, that their efforts made a positive impact for their patients, and that they plan on incorporating this into their future practice. In sum, more than 46,000 patients and colleagues initiated new voter registration or requested mail-in ballots using the VoteR platform during the intervention period. 1/3 were a direct result of the medical school competition. Overall, we conducted a successful and widespread initiative to promote civic health in healthcare settings. Some key strengths that stand out from prior work include the ease, scalability, and trackability of our digital approach, and the remarkable variety of participants across settings and roles. Another key insight was the effectiveness of gamification in motivating participants, particularly those from rival institutions in our med school competition. As signified by the vast majority of these students stating that they will incorporate it into their future practice, this work struck a chord within the House of Medicine. We envision a future in which civic health is part of a routine medical care, and every hospital, clinic, and urgent care provides voter registration services. We've received countless inspirational stories from patients and providers alike about the personal impact of this work, particularly during an otherwise tumultuous year. In future study, we're excited to further explore the short and long-term outcomes on voting practices, health measures, and civic attitudes. I want to close by acknowledging the incredible efforts of our healthcare partners, including a huge number of emergency physicians and many of you in this audience. Your actions elevated the voices of your patients and enabled them to vote safely. So thank you. Here are my references, and feel free to email me if you have any further questions.
Good afternoon. So to start off, I have no financial disclosures. On January 4th, 2020, the World Health Organization announced on Twitter that there was a new cluster of pneumonia cases coming out of a province in China no one had heard of. It was an over there sort of problem that we didn't really think much about, but of course we did need to think about. And now, the rest is history, over 100 million cases worldwide of COVID-19. The FDA on December 11th of the same year finally announced emergency use authorization for a COVID-19 vaccine, a really big deal. And it was on Twitter. So again, we see Twitter being used for public health dissemination, really important. ER doctors were no exception. And we saw, professional organizations, individuals, they were coming online to debate, to share perspective, to vent, to seek evidence, and serve as a kind of canary in the coal mine for, what was going on the ground. So my name is Colton Margus. I'm an emergency physician by training, and I'm also interested in disaster medicine and disaster response. So yes, this is another talk about COVID-19, but it's also not a talk about COVID-19 in the sense that I'm talking about Twitter, specifically how social media pertains to the surge. So what I want to convince you of is that Twitter can tell us a lot about emergency physicians and how we talk online. And there may actually be evidence in that conversation of the surge and even before it happens. And so what I'm trying to say is that what we say actually does matter a whole lot, turns out. So to do that, I have to talk to you about the participants. So we gathered all the followers of Twitter, of SAM Online on Twitter, and even some other professional organizations. We put them all together. We removed those with protected accounts or who were not clearly EM physicians or didn't live in the United States. But that's not everyone who uses Twitter. I don't follow those professional groups necessarily. So we want to account for those people too. We pulled the followers of those followers and did this whole same process. And we ultimately had about 3,000 physicians online. They were mostly since 2020, but even a few came before 2010 in terms of when they started using Twitter. And although most people don't mention their gender online, about 50-50 of those who did. And then all regions were pretty much covered, even US territories. They produced about 2 million tweets. And we did have to remove the tweets outside of the study period, which was from the first mention of COVID to the first vaccination. And we also excluded retweets and non-English tweets, but you still had 300,000 tweets to work with. What did we do? So we first conducted sentiment analysis through natural language processing. You'd get a full one would be the super happiest tweet, and then a negative one would be the most devastating, for example. And when you plot that on a daily basis, the average sentiment among the ER doctor tweets, you get this white line. The red line is COVID-19 hospitalizations, and there doesn't seem to be much correlation. But what is interesting is that you do see some correlation with events that were going on in the world. We also did what's called topic modeling, which is another machine learning method that will actually the best way to describe it is you make a bag of words, and the words that are correlated with another bag of words will be put in the same topic. And so this is, for example, the word clouds of the 20 topics that were created from this group. Topic 4, for example, would be maybe evidence-based medicine, for example, and then topic 18 would be medical education. So there's not all that much correlation with case counts, but what I'd like to bring attention to is the inpatient bed difference. So the COVID-19 related topics were much more correlated with inpatient bed use, which kind of makes sense. It says a lot about how ER doctors are gatekeepers pretty much of the disposition for hospitalization. And so this is the slide that really is the take-home one. You have to pick one. So the red line is, again, the COVID-19 hospitalizations, while the white lines are tweets related to COVID-19. While the dotted line is a 7-day moving average, the solid line is a more smooth 28-day moving average. So if the 7-day goes over the 28-day, it is a kind of indicator of momentum. And what you see is, besides the obvious correlation between the white and red curves, you see that the momentum indicator that I just mentioned, where the 7 days going over the 28-day, really precedes the major curves. That's pretty cool. So again, I'm an emergency physician. We're talking about emergency medicine, and what it looks like is that ER doctors talking online, they actually anticipate surge. That's not that crazy to think about. I just finished residency in New York last year, so I was in March in New York last year. I was seeing this tent. And I became pretty convinced from that experience that we as ER doctors are uniquely positioned to serve as indicators in a way of the healthcare system and its strain. So Twitter data can probably and should be used to better understand all this. And it really turns out that even the most mundane of social interactions, unintentionally online can serve as this barometer of what's coming. And most importantly, may be vital to pandemic planning and response going forward. Thanks very much for listening to me.
Hi everyone, I'm Devin Arganall. I'm one of the third-year emergency medicine residents at Cleveland Clinic Akron General. I'm really excited to be doing this presentation on our research today. Our research looked at the evaluation of the impact of trauma activation on the time to imaging and emergency department disposition in geriatric patients presenting with ground level falls. All right, so just to get into an introduction here, falls account for 75% of trauma in elderly patients, yet ground level falls often do not meet criteria for trauma team activation. This underutilization of trauma team activation can contribute to poor health outcomes for geriatric patients, and it is difficult to balance under and over triage. If you over triage, then you are wasting time, money, etc. with these trauma team activations, but with under triage, you could potentially be delaying care and causing harm in this patient population. So the aim of this study was to evaluate whether a trauma team activation improves patient care for geriatric fall patients. Our primary objective was to evaluate the difference in the average time to diagnosis between trauma team activation and trauma evaluation groups. Our secondary objective was to evaluate the effect of trauma team activation on the timing of treatments and hospital course. For our methods, this was a retrospective cohort study that was conducted at our Level 1 Trauma Center in Northeast Ohio. Our cohort included all patients aged 65 and older who presented to Cleveland Clinic Akron General for a fall between September 1st, 2017 and August 31st, 2019, and had either a Level 2 trauma activation or a trauma team evaluation. Exclusion criteria included things that would delay care or alter care, such as being a DNR or being a transfer from another facility, and then we also did not include Level 1 activations. Our statistical outcomes were evaluated using the unpaired students t-test. So before getting into our primary and secondary objective results, I wanted to highlight this table of our patient demographics to highlight that the two groups were fairly similar. You can see in the middle column, the trauma team activation group compared to the most right-sided column, the trauma evaluation group, that these groups were very similar as far as variables like age, dementia, renal failure, etc. I would say the trauma team activation did have high rates of things like bleeding disorders, things that would usually upgrade someone to an activation. But again, this highlights the need for looking into other variables that could determine trauma team criteria. So table 2 is looking at our primary objective, the difference in average time to diagnosis between the two groups. And as you can see, the trauma evaluation group, the average time was 153 minutes compared to the Level 2 trauma team activation group, which was 56 minutes. And that was statistically significant, significantly longer time in order to get a diagnosis for the trauma evaluation group. Table 3 is looking at our secondary objective, the effect of trauma team activation on patient mortality and the proportion of patients that return to the emergency room for trauma-related illness within 30 days. And again, the trauma evaluation group has significantly worse time. They had longer hospital length of stay, 92 minutes versus 75 minutes, longer time to anticoagulation reversal, 194 minutes compared to 74 minutes, and then longer times to hospital admission, 311 minutes compared to 162 minutes, and all of those were statistically significant. This graph highlights the difference in timing of clinical interventions, time to first X-ray, time to transfusion, time to ED discharge in minutes. And the blue bar represents a trauma team activation, and the red bar represents a trauma evaluation. And as you can see, with the red bar being quite a bit higher than the blue bar for all interventions, the trauma evaluation had much longer time to get these interventions done. The second graph looks at clinical outcomes between the two groups. So again, looking at the blue bar that represents the trauma team activation compared to the red bar that represents a trauma evaluation, the trauma evaluation had higher rates of inpatient admission, higher rates of intracranial hemorrhage, and then higher rates of need for anticoagulation reversal and transfusion. So in conclusion, the trauma team activation group received improved care compared to the trauma evaluation group. The consult group, the trauma evaluation group, had worse trauma severity index scores, higher rates of intracranial hemorrhage, higher need for anticoagulation reversal, and higher rates of hospital admission. But despite that worse morbidity, they had worse time to anticoagulation reversal, worse time to diagnosis, worse time to imaging. So really the two don't match up great, highlighting a need for improved trauma activation criteria in this geriatric population. This study highlights the need for future studies looking at some of these variables that may be predictive in better evaluating what variables can be predictive in creating trauma criteria. And future studies should also look at Category 3 trauma activations as a potential area of improvement for this group of people where it's unclear if they need to be a trauma team activation or not. And I wanted to say thank you to my great team who helped and made this project possible. And thank you so much, everyone.
Hello, my name is Anthony Nardone. I am a fourth-year medical student at UCSF, and today I will be presenting my team's work titled The Impact of the COVID-19 Shelter-in-Place Order on Traumatic Brain Injuries in San Francisco, California. We have no disclosures. WHO declared COVID-19 a pandemic on March 11, 2020, and just 5 days later, the counties of the San Francisco Bay Area declared a shelter-in-place order, the first of its kind in the country, which effectively closed all non-essential businesses and discouraged non-essential travel. During this time, emergency medicine physicians in San Francisco anecdotally noticed a drop in trauma cases. And this anecdote was representative of what was happening in emergency departments across the country. Pictured here is a graph from the CDC's Morbidity and Mortality Weekly Report from June of last year that shows 2019 ED visits in the light blue line and 2020 ED visits in the dark blue line, with weeks of the year on the x-axis. There is clearly a very noticeable drop-off beginning around week 10 in 2020, which aligns with the WHO's declaration of COVID-19 as a pandemic and the initiation of shelter-in-place orders across the country. You can also see that around week 16 or 17, ED visits begin to creep back up towards a normal level. In addition to this overall drop-off, multiple studies in the US and abroad confirmed what EMPs were noticing in San Francisco, namely that trauma cases were declining during this time period. One potential complication of trauma is traumatic brain injury, or TBI, and TBI has a wide spectrum of severity ranging from minor head trauma to coma or even death. During a normal year, there are over 50 million cases of TBI worldwide, and this injury can cost the global economy up to $400 billion annually. Given the dynamic landscape of COVID-19, understanding who is impacted most by TBI and the mechanisms that drive TBI during these shelter-in-place orders is important for both allocating future resources and for reducing morbidity and mortality. However, no studies to our knowledge have assessed TBI trends during this time. This study was a retrospective analysis of patients presenting to the ED at Zuckerberg San Francisco General Hospital between December 15th, 2019 and June 15th, 2020. This is the only trauma center in the city of San Francisco. Records for patients with ICD-10 codes corresponding to acute head injury were included and reviewed by the study team to ensure accuracy and exclude any erroneous medical records. We then assessed overall changes in TBI presentations, demographics of TBI patients, and mechanisms of injury. During the study period, there were 1,342 visits for TBI, 58% of which were in the 3 months immediately prior to shelter in place, and 42% of which were in the 3 months immediately following shelter in place implementation. Compared to the month immediately before shelter in place, there was a 37.4% reduction in TBI cases in the 30 days that followed shelter in place implementation. Some other big picture highlights of our results include that we saw far fewer patients who were school-aged, that is age 17 or younger. We saw that patients were on average more likely to be male, older, and more likely to have experienced a ground level fall during shelter in place. We saw a drastic 38% increase in TBI related to cycling during shelter in place. And then lastly, we saw no changes among racial demographics of TBI patients between shelter in place, before and after shelter in place, though we did see a slight increase in the proportion of those who identify as non-Hispanic ethnicity in the time following shelter in place implementation. Our findings are consistent with other trends identified in the emergency department at this time, notably that our measured outcome was less frequent during shelter in place. The decrease we saw in pediatric TBI cases was likely a result of decreased organized sports and school activities. The significant increase we saw in cycling accidents correlates well with the surge of interest in cycling across the country. A recent study published in PLOS found that bicycle counts in New York City, Seattle, and Houston all significantly increased during the pandemic. In San Francisco and many of the surrounding cities in the Bay Area, main roads were closed down for pedestrians and cyclists in order to increase access to outdoor spaces. Pictured here is one such lovely, crowded space, the Great Ocean Highway along Ocean Beach in San Francisco. Our findings undoubtedly reflect increased use of these types of spaces and also likely inadequate infrastructure, helmeting, and signage to accommodate such increases. We also found that patients with TBI were older during this time period and more likely to have experienced a ground level fall. The combination of these two factors likely indicating increased vulnerability of older patients during shelter in place. Deconditioning, vitamin D deficiency, and increased social isolation among elderly folks during COVID-19 shelter in place orders have all been documented. And thus, future resources should really be allocated to ensure that at-risk populations, such as the elderly, not only avoid COVID-19 or a pandemic of the future, but are also able to access vital services during these time periods. Some limitations of our study include that data was only from one hospital and thus may not be representative of the entire region. It's also uncertain how much of these decreases in TBI represented true decrease in the TBI incidence versus a decrease in the willingness of people to go to the emergency department during a pandemic. Thank you so much for your time. I'm happy to take any questions now.
Hi, everyone. My name is Matt Chaya. I'm a medical student, and this is an abstract presentation on non-fatal injuries from mass shootings. The co-authors are Dr. Mark Langdorf of University of California, Irvine, and Dr. Chad Kraus of Geidinger Medical Center. Unfortunately, we're all familiar with mass shootings as they feature prominently in the media and have been increasing in frequency over the past 30 years. There's actually been very little research studies done on mass shootings, and only one that includes non-fatal injuries. So non-fatal injuries are the major contributor to the firearm violence epidemic. For every death, 2.5 are treated for gunshot wounds and survive. However, most firearm violence studies focus on deaths, and the media and scientific community essentially overlook non-fatal firearm injuries. And these are a few media headlines which demonstrate that they include the number of deaths, but not the number of injuries. So the objectives of this project are to describe the epidemiology and healthcare burden of the non-fatally injured victims and to better understand the implications to hospitals and communities. And we will be looking at gunshot wounds and non-gunshot wounds. This project will feature 14 consecutive mass shootings from 2012 to 2019, and it's a retrospective chart review. This is a flowchart showing the study inclusion, and we started by searching public databases, Mother Jones and the Violence Project, for shootings with greater than 10 injuries, and we identified 15 that way. We also identified 7 additional shootings for a total of 22 that we targeted for inclusion, and data was available for 14 of these shootings, which coincided to 18 study sites and 40 hospitals. This is a table showing you the 14 study sites and the number of injured patients, deaths, the ratio of each, and the percent included from each. So 2 sites thus far are reporting 184 patients. The median age was 33. It was predominantly Caucasian. The ambulance was the most common mode of arrival. 2/3 sustained a gunshot wound. Another 1/3 sustained non-gunshot wound injuries. Of those, fall, stampede, and trampling mechanisms were tied with laceration and external trauma for the mechanism of injury. So of the total body regions injured by gunshot wounds and non-gunshot wounds, extremity was the majority at around 60%, followed by head and neck at 12, chest and abdomen. So for the organ systems injured by gunshot wounds, the most common was muscle, followed by bone, then by lower respiratory tract, and then GI tract. So of all the patients in our sample, about 1/3 had ED procedures. Perhaps not surprisingly, most of them were laceration repairs, although a little over 10% were intubations. 30 patients had at least one OR surgery, and all of them except for one were performed within 24 hours of arrival, and 9 patients had multiple OR surgeries. So about 2/3 of the patients were discharged home and another 1/3 were admitted. The median length of stay for the admitted patients was 3 days. This median length of stay increased to 5 days for the 19 ICU patients, which represented about 1/3 of all the admissions. And then importantly, about half of the admitted patients had a functional disability at discharge, and 10% were sent to rehabilitation. and the median hospital charge is shown here. So real quickly, this is a summary of the key findings. For every death, there were 2.7 injury victims, 2/3 sustained gunshot wound, 1 in 3 require ED procedures, nearly 1 in 5 required OR procedures, 1 in 3 require hospitalization, 1 in 3 of those admissions are admissions to the ICU, and 4 in 10 patients had functional disability. So in conclusion, there's substantial burden to patients and society and hospitals, impacting both trauma centers and community hospitals. Unfortunately, there is no region that is protected from the potential threat of a mass shooting, which can overrun a single coverage ED, as well as overrun a level 1 trauma center, as we've seen in other mass shootings, most notably Las Vegas. So the results of this study amplify the impact of deaths and finally add some value to the non-fatal injury statistics that have been overlooked thus far. And hopefully the results of this study may inform public policy efforts and public health efforts to prevent harm from future mass shootings. One thing we learned was that mass shooting epidemiology is definitely complex. Our final study will include a catalog of all the injuries according to diagnosis codes and discharge summaries. And one last thing that we need is more research, and we need better data collection and dissemination methods in order to more fully study mass shootings and their injuries. I would just like to acknowledge everyone that was involved. It's quite a few people. This was a multi-collaborative effort, and it wouldn't have been possible without all of these people involved. Thank you for your attention.